¿Se escucha? Sí. Muy bien, tenemos la suerte de poder escuchar al doctor Robert Rogers, que viene desde Baltimore, donde se desempeña como profesor asociado de Medicina Urgencias, es director del Fellow de Educación Médica y director de The Teaching Curso de la Universidad de Maryland. Este exponente de clase mundial hoy nos presentará la conferencia Afinando la vista. Un aplauso para el doctor.
Hola, buenos días. Mi español no es muy bueno, so I'm not going to even try. All right. Okay, so welcome to Visual Diagnosis. And I want to thank Pablo and Isabel, everybody who's invited me to come to this conference. This is a great place and a great city, and it is absolutely an honor to be here. Now, I went to dinner with the important people last night who run this conference, and I have to tell you, I hear that Pablo's a busy man. But as I looked through some of his pictures, I started to wonder how much he truly does work in the hospital. Does anybody else get to do this during their clinical shifts? So evidently, Pablo is eating cake and ice cream and sleeping, but I'm sure he works hard. And the faculty seem like they work really hard here to teach the residents how to practice emergency medicine. You truly are special. Can you set the timer? Can you set the timer? Where's Oscar? I could not resist that. There he is. So the faculty here are amazing. The residents that I've met are amazing. And this audience is very energetic. And so what I really want to do over the next just couple of minutes with you is, number one, give you a warning sign. And that is the pictures and things that I will show, many of them are absolutely disgusting. But this is emergency medicine. This is what you do every single day. Mel Herbert likes to say that what you do matters. And I would go one step further by saying what you know matters. You have to deal with all kinds of stuff when it comes into the emergency department. No other specialty can handle and take care of the things that we see day in and day out. You need to be ready for everything when it comes in. Doesn't matter what it is. You have to know how to manage it, take care of it, who to call, how not to panic. So you are emergency medicine. What you know truly does matter. So many of these are cases that came into our emergency department. Many of them are not great mysteries. But what is the diagnosis here? Anybody know? Show you a couple more pictures. This is a picture of, this first picture is a diabetic who came in with a fever and very low blood pressure. And the next patient, this is not what you want to see when you're working, right? This is a diabetic with Fournier's gangrene. This is pretty easy to recognize, and you would admit that this is also very easy to recognize. But necrotizing fasciitis is a very serious diagnosis, and you have to be equipped to pick up these diagnoses when they come in early. These are cases that came in later. Here's another case. You can look at this and see how this could be confused as a simple cellulitis and perhaps an abscess on top of that. But it turns out this was a diabetic who is very sick, very low blood pressure, high lactate. Clearly, this is a necrotizing soft tissue infection, and the treatment of this would be to take the patient to the operating room. So these are pretty obvious diagnoses, but being on the front line in emergency medicine, you have to know how to walk in a room and look at a patient and say, necrotizing fasciitis. We are the experts, and what you know matters in those initial minutes, learning how to recognize sick patient with this appearance. These patients have to be acted on very, very quickly. Now, you don't see this case every day, and it highlights the fact that you have to be ready for everything. Do you have any patients in Chile who have psychiatric disease? Yes, everybody has patients with psychiatric. So this is a patient, schizophrenic patient, who was diabetic, and the voices told her to take her insulin and inject it into her eye. And what this picture shows, so the patient's right there in front of you, what do you do? Well, we didn't know, to be honest, But again, this highlights the fact that we see everything when it comes in, and we are the front lines in medicine. So here are some air bubbles here in the anterior chamber. This person had an elevated intraocular pressure. We were able to get some help from an ophthalmologist, and what do you think they did? They put another needle in the eye, and they literally took out the air bubbles. And so again, very weird case, very strange case, but when you go into your next shift, just realize anything can come in. And I'll highlight that with a few more cases here in just a minute. Now, this is one of my favorite cases because it shows and highlights that not only are we at the front line, but we sometimes have to be creative and innovative when we take care of patients. It's not enough to open up a textbook and say, this is how you do it. We sometimes have to think a couple of steps ahead. This is a patient who came in with rectal and abdominal pain, and one of the residents decided to get an x-ray. I'm not really sure why, but they decided to get an x-ray. This patient only told us that he had rectal and abdominal pain. And we noticed that there was something right here where it shouldn't be. Would you agree? There's maybe something there. And we went back and talked to the patient, and he told us that he inserted a dildo in his rectum. That's what he told us. Now, I have a point, I have a teaching point. There's a reason I'm telling you this. We called surgery to come down to the emergency department. We couldn't pull it out. The surgeon couldn't pull it out. We tried everything in the textbooks. We tried red rubber catheter. We tried a Foley catheter. Every time we pulled on the foreign body, it got stuck and went higher and higher and higher. And so I said to the surgical resident, perhaps we could use a bougie. And her response was, what is a bougie? So we went to the airway cart and got a bougie, and we actually went and got 2 of them. And what we did was we inserted the bougie past the foreign body, which I'm going to show you in just a minute. And we were able to break the seal by putting 2 bougies past the foreign body and breaking the air seal. And the surgery attending, jokingly, and actually then after the fact, seriously, said that we should call this the Rogers maneuver. Well, that's my name, Rogers. And I don't want any one of you to go to Google and type my name in and see a picture of a dildo. That generally wakes most people up in the audience. So this patient was very nice. He consented for this. And so the point here is that everything's not in the textbook. Sometimes you will have to be creative and think about different ways to do things. And this patient was about to go to the operating room, and we prevented the patient from an operation. So that's a pretty big deal. All right, now I highlight this to show that, again, transplant patients, and it depends on where you work and what country you work in. Where I work, we see lots of transplant patients, liver transplant, kidney transplants. It depends on where you are in the world. Spain does lots of transplants. Some places clearly don't do any transplants, but this is a patient who had a self-inflicted gunshot wound. He was a suicidal attempt, but basically all he did was take off the front part of his face, mandible, and this is what he was left with. So he actually received a face transplant at our hospital. This is probably a 48-hour procedure, and this is what he looked like about 2 weeks after the procedure, okay? So here he is 2 weeks out. This is a couple of months out. So they basically took everything off. Part of the neck, they had to do the carotids, they had to do everything. And here he is in series. This is what he looked like before the gunshot blast to the face. This is what he looked like afterwards. And this is what he looks like post-op. Now, just imagine, and here's a recent picture of what he looks like a year or so out. Why do I show this? How do you treat this patient if he comes in with facial swelling and you think that he's rejecting his face? Right? People reject their kidneys, their liver, their heart, their lungs, other cornea, and all of these other things. What if he comes in with facial rejection? Who knows what to do? And we really wouldn't know what to do either. We would probably call a specialist. But again, anything can come into the emergency department. Anything. They are going to come right to you 24 hours a day. All right. Just to show a couple of videos here of some of the things that we've done in our emergency department. Who here uses intraosseous lines in kids? Anybody use them in adults? These are fantastic. If you don't have one, we were talking in the back about how much they cost to get, and I know cost can be prohibitive. But in our hospital, at least, and many other hospitals, when a patient comes in cardiac arrest, we would traditionally put in a central line, right? Subclavian or a femoral line, and it's bloody, and it takes a couple of minutes to do it, and it doesn't always work. But now you can put in intraosseous lines, and I just wanted to show the flow rate. So here, that's the line going in, right into the tibia. And then if you look on this film right here, this is about what you would get with flow rates. So if you injected epinephrine, even if you gave blood products, fluids, other cardiac drugs, this is how fast the flow you would get. Hold on. There we go. So that's in real time. So just with a push, and you have to push pretty hard, you get pretty good flow rates into the central circulation. It's almost as good, and I would say it's just as good as a central line if you're having to resuscitate a critically ill patient. You get very, very good flow rates. Now, the other thing about emergency medicine is nobody on the planet has as many good chief complaints as us. Right? Raise your hands if you've picked a chart up and just laughed out loud at what the patient came in with. Look at all the hands. So we see just crazy stuff. And I don't have a lot here. I'm going to show more tomorrow. But this is a patient, and basically, I'm not going to even try it in Spanish. The mom said, my kid ate some poop, some caca. That was the chief complaint. I don't know what you do with this. Well, how do you take care of this patient? All right. Yep. That's what you call an awkward segue right there, ladies and gentlemen. Now, why do I show this? Where do you think this guy's going to go when he comes to the hospital? Well, I can tell you he's not going to the dermatology clinic. He's not calling up the urologist who's not going to answer the phone. He's coming to see you. What do you do with this? Think about it. It's your shift, right? I see. Did someone say tourniquet tech? Like you would get a ring off the finger? You can try that. I don't know if that's going to go over very well with the patient. So this thing's not coming off, right? What do? Hope that your shift is over in 5 minutes and you can sign it out to your partner? Pablo says, my shift is over. This is your patient. What do you do with this person? Is there anything you have in the emergency department that will get this off? Pardon the expression. No, we have nothing. What about ring cutters? Don't even think about it. This is steel. So you have to think a couple of steps ahead. And with this patient, they had to call they had to basically get industrial equipment to be able to saw this thing off in the operating room. The hospital didn't have the equipment to get this thing off. So you have to be prepared to take care of this, believe it or not. And there are patients who do all kinds of things and they come in to see you. You've got to be prepared. So it's not enough just to read the textbooks and the articles. You've got to imagine what people do to their bodies. They will be coming in to see you to take care of it. And you have to be comfortable with some of these crazy things. Now, you might ask, why was this x-ray taken with a gun? And so it turns out this patient came in with abdominal pain. And do you think that the resident actually did an abdominal exam before ordering the x-ray? No, he didn't even examine him. So he sent the patient to radiology, and the radiologist calls over and says there's a metallic foreign body obscuring full view of the pelvis. Well, yeah, because there's a gun under the patient's gown. Nobody checked, and sure enough, they went back and they pulled a gun out, and he said, yeah, I brought a gun into the emergency department. So you have to examine your patients sometimes. Okay, a little quiz. This is a patient on hemodialysis, been on hemodialysis for many years. They've had all kinds of lines in the chest, the neck. They've gone through fistulas. They've had all these complications. What type of dialysis access does this patient have? Think about it for a minute. Why would I show you the skin on the abdomen? So this patient came in and said that over the course of a couple of weeks, he had developed these very large, he called them varicose veins, but very large veins on his anterior abdominal wall and here and then out in the flank. So this skin finding, when you see large, vertically oriented, dilated, superficial wall veins, that's almost pathognomonic for an IVC clot, a clot in the inferior vena cava. So it turns out this patient had a translumbar vena cava dialysis catheter. So by CAT scan, they guide it into the vena cava through the back, up into the vena cava, and that is their access for dialysis. And it turns out this patient came in with a clot in that catheter, and they presented with the classic pathognomonic skin findings of IVC thrombosis. Where else might you see a patient with IVC thrombosis? So post-trauma, maybe a liver mass, a large pulmonary embolism, DVT, some of those things. But this is a patient with catheter-induced thrombosis. And this is what the CAT scan might look like. This is all clot right there, all the way up into an IVC filter. And over the course of weeks to months, they'll develop these very classic vertically oriented veins on the abdominal wall. You will look brilliant if you know that clinically. You'll say, aha, that's IVC thrombosis. All right, let's talk about some simple stuff that comes in. What is the diagnosis here? Somebody say it. Epidural hematoma. Nice shape here. This is a very classic epidural hematoma. Here's a patient with a sudden onset headache. For the residents in the room, what's the diagnosis here? Right, classic subarachnoid hemorrhage, right? All right, now, here's a patient who comes in. We see lots of dental pain pretty much everywhere on the planet, right? Everybody's got dental problems. And here's a patient who comes in with some facial swelling. He's a little tender right here, a little swollen, says it hurts when he chews. And the number one pitfall, the number one thing missed in patients like this is a good oral exam. So when the resident went to open his mouth, luckily this resident looked, what is that right there? Now he's got horrible teeth, actually not too bad, but so he's got cavities. He had a couple of places where he probably needed some antibiotics perhaps. But there's a stone, so he's got sialolithiasis. He had a stone sitting right there that we were able to just sort of pluck out, and that was what was causing his jaw swelling and pain. So make sure that you do a good oral exam, because the clue to the diagnosis, the clue to the treatment, to making this guy feel better, is right there and it's looking right at you. All right, here's a patient who comes to see you. It's 2 in the morning. They had an abdominal aortic aneurysm repair at another hospital. They come to see you, and this is what they have. They look pretty good. Their vital signs are fine, but their foot hurts. So what's happened? What do you have to assume is present? So this patient, it turns out, number one, you have to worry about a clot from the repair flipping off distally and going to the foot, right? Turns out if you look at the other foot, not so bad, right? So this is called the blue toe syndrome. You can see this very frequently before abdominal aortic aneurysm repair, and you generally see it in both feet, right? So most AAAs, or aneurysms in the abdomen, have thrombus, mural thrombus, and those little clots will flip off downstream and go to both feet, and they'll present with painful blue-looking toes. So if you didn't know this patient's history, or he'd never had a repair, and he came in with what looks like this in both feet, they look blue, they're very painful, you have to assume that they have an aneurysm in the abdomen. That's the teaching pearl here, okay? All right, here's a person, diabetes, high blood pressure. Do you see patients with diabetes and high blood pressure in Chile? maybe a couple. So this patient was clearly not taking care of himself, and he had a history of chronic kidney disease. He'd been at home for several months. His family hadn't seen him, and he came in vomiting, hypotensive, with this appearance. Take a look at it for just a minute and see if you know what's going on here. Don't see this very often, but I think you're probably going to see this more in other countries, especially with poor dialysis access. Here's another appearance here. This kind of frosty looking appearance. Go back to this picture here. Kind of not very specific, but kind of frosty looking. I'm giving you a clue here. See here, looks like frost. So this is uremic frost. This is the skin finding. Have you got anybody in the room seen this before? It's pretty impressive. And generally when they have this, they're sick. They're acidemic. They're generally hypertensive or septic. A lot of stuff's going on. So this is the skin finding with dialysis. All right, about 10 minutes or so to go here. One of my favorite cases in residency was this. And this is where I think you can make a big difference. This person came in and they said, my voice is hoarse and something just feels wrong. And they just kind of did this. That's about as good as we could get out of their history. My throat feels funny. I know Billy's going to talk about sore throats later and some other things. So it didn't really hurt. She just said, my throat feels kind of funny. And her other complaint was, my arms are itchy. So you're working, and a patient comes in and says, my arms are itchy and my throat feels funny. What do you do with that person? Sign it out to your partner. Maybe your shift is over. So we didn't know what to do. This person looked fine, but they were just scratching and scratching and scratching. And her sister came in and said her voice sounds hoarse, sounds different. So the attending faculty member that I was working with said, let's get an x-ray of the neck. And I said, why? And he said, I don't know. Let's just get one. So we got one. And it's one of those things where the voice just tells you, get an x-ray. Something's going on with this person. And if you can tell from this x-ray, the soft tissues right in front of the vertebral column look a bit thick, right? Very generous, not that nice thin stripe. Here's another picture here showing the very thickened prevertebral soft tissue column. Not the same patient, but a similar diagnosis. What you would see is these just very edematous right here, right? So we're wondering what to do with this person. You know, she's got this edema, she doesn't have a fever, she looks okay, she's scratching, scratching, scratching. We never figured that part out. And she starts to develop stridor after about an hour. So we realize she's going to have to be scoped, probably by ENT, go to the intensive care unit. We don't really have a diagnosis yet. The intensivist comes down, and he examines the patient. We probably could have done a better job with that, and feels a catheter, portacath for chemotherapy. Turns out she should have had that removed a year ago, never got it removed, right? So what this lady ended up having was thrombotic SVC syndrome, presenting with laryngeal edema, right? And so the attending was right. Something's going on with this person, and I'll show you a couple of other cases. Here's another patient where if you look at this picture, he looks pretty normal. I mean, he didn't look abnormal to us. He said, my face feels like it's going to explode. That was his chief complaint. Now, we took out his driver's license, and this is what he looked like about a year ago when the picture was taken. Do you see the difference? So this is a really good trick to use if you can get a picture of the patient and look at it. If they ever tell you that their face feels different or swollen, this is a very classic complaint. You'll hear other things which we'll talk about. But this person just said, my face feels swollen, it feels like it's going to explode. We looked at the picture, we realized he is swollen. He didn't look swollen if this is all we had to look at. He looked normal. Look at this, he's swollen. And if you look at him side by side, clearly he's lost these features here, he's edematous here, and he ended up having a lung tumor with a SVC clot right beside it, causing SVC syndrome. His only complaint was facial swelling. Maybe a little cough, but mainly facial swelling. Here's another picture to show what patients will come in with, and they'll tell you that their face gets more swollen in the morning and will look a little bit more normal as they're upright and they drain some venous drainage from the face. But they will very classically tell you that their face feels more swollen when they wake up in the morning. Here's another patient with a lung tumor who, you can tell the difference here. In the morning, he's lost some of these folds here. He's edematous around the eyes. He's lost some of the folds in the bottom part of the face. So just based on history, my face feels swollen. In a smoker, you would have to think maybe they have a lung tumor or something going on in the vena cava. I don't think you see this sign very often, but the more I read about it over the last decade or so, the more I looked for it, the more I realized we probably were just not paying attention to this. Many patients, if you ask specific questions about facial swelling, they'll tell you this in their history. They will tell you that when they raise their arms up, their face gets red. You ever seen a patient like that? If you ask that question, or you ask them if when they bend over to touch their toes or to tie their shoes or to pick something off the floor, their face feels like it's going to explode and gets very red. And this is a patient with Pemberton sign, right here. This is arms raised, really red, arms lowered, back to normal. And this is a patient with a lung tumor causing SVC compression. So you can get at the diagnosis with many of these things just by asking the right questions. Here's another case, red, swollen, arms up, arms down, the redness goes away. You can do that at the bedside. It doesn't cost any money. You don't have to get a CAT scan. And based on this, you would need to think about what would be causing this. So good physical exam, good history can get to some of these things. Here's another example. Also, things like goiter, large thyroids can cause this. And here's a patient, arms up, face red, arms down, redness goes away. That finding tells you that there's significant venous hypertension in the head and neck region, right? So you have to think about those things clinically. Now, the other thing that I think about actually being a doctor and working in a place where you have to do good physical exams and take good histories, and you can't CAT scan every single patient who comes in like we do in the United States, is the physical exam really holds the key to a lot of these things. You look at these pictures here on this slide, and you could see how in the emergency department where it's very loud and chaotic, you might not pick up on this if you do a very brief exam or you skip parts of your physical exam. But when you look at this, you see these veins right here on the chest wall. They might not be new, but they might be new. Look on this patient, I'll show some more examples, a little bit blurry, but there's some veins that have dilated mainly on the left side of his neck and his chest. That may very well be the diagnosis. And just by looking and being detailed, you've picked up on it. Here's another case. This is not SVC syndrome. This is a patient who had had a catheter in the hospital, came back in with some neck, said his neck felt funny. He looked pretty normal. And based on this picture, we realized what the diagnosis was. Just looking at it. Walk in, take the history, look at his neck. We have the diagnosis. Now, we did get an ultrasound, but we knew what the diagnosis was. This person had an internal jugular thrombus, and it had propagated into the junction and almost into the SVC. So you can see your physical exam, and he had none of these veins on the other side. So your physical exam matters. What you see on exam matters, and this didn't cost any money to perform. Now, this is a little bit more obvious. You can see in this picture, he's got asymmetric chest wall veins that are dilated right here, here. The problem with this, many patients won't know if they're old or if they're new, right? You ever ask a patient where you see something and say, how long's that been there? And they say, I don't know. So sometimes you don't get much help in this, but if a patient says, yeah, I've noticed these veins popping out on this side, something is going on. This is what you're going to see if you even need to get one, which is the answer is probably no, but if you do a reconstruction on CT scan, when the SVC gets obstructed, you get all these engorged, enormous collateral veins in the chest wall, which you can see on CAT scan, just to show what that looks like. And basically the reason they present with, remember my case, the laryngeal edema, the lady with the sore throat, the weird throat thing, and they can also present with headache, which is an indicator of cerebral edema. Those are the two big things, cerebral edema, laryngeal edema. And this is why it happens. You have a tumor compressing the vena cava here. You get this huge venous engorgement. The head and the neck region can't drain. and all of that venous drainage just kind of builds up. And they end up with swollen prevertebral soft tissues and increased intracranial pressure. Those are the two big things. All right, clinical clues. When you see a patient with facial swelling, if they tell you their face feels swollen or it changes or feels worse when they do certain maneuvers like bending over, tying their shoes, arms above the head, you have to suspect they have either a tumor or a catheter that they had that has now caused a thrombus. And if anybody comes in with an indwelling catheter in the subclavian or anywhere up here with that complaint, they probably have a clot in their superior vena cava. So just be on the alert for that. Here's a lung tumor causing SVC compression, and what you would see on CAT scan, big long mass causing SVC compression. So picking this diagnosis up is going to depend on you. Are you listening to the clues of facial swelling, the laryngeal symptoms, and the headache? Some more pictures here. IJ, subclavian clot. Again, the diagnosis was made as soon as we looked at that. Very obvious sometimes. All right. Well, I'm down to 30 seconds. I've got probably 2,000 slides, which I could do forever, and I'm not going to, Isabel, just so you know. My purpose of this over the last 25 minutes with the few cases I could show was to make you realize that what you know matters, what you do matters, and try to be creative and innovative with the patients that you see. You will have to do more than the textbooks tell you to do. So with that, I will end, and I hope to see all you guys tonight. Thank you very much.
Muchas gracias, Dr. Rogers. Ahora vamos a pasar a la siguiente presentación.